Okay, I think we'll get started. So good morning, everyone. And thank you for attending this the webinar that Crime Stoppers of Halton is hosting and partnering with, obviously, the Halton Regional Police and CMHA Halton. So today's webinar is called In Our Backyard, Opioid Use in Halton and How to Help. And I'm Detective Constable Nadine Clark, the police coordinator for Crime Stoppers of Halton. And I'm just going to pass it over to Sergeant Rick Judson, who is the sergeant in the RCMB in charge of the mental health unit.
Good morning, everybody. As Nadine said, my name's Rick Judson. I'm the sergeant for the Regional Community Mobilization Bureau. We're involved in a lot of community outreach and community collaboration. I'm not going to take up a lot of your time. I know everybody didn't tune in to hear me talk. And if we were in person right now, I would probably keep you for about a half an hour because I go on side notes, but I won't do that today. I just wanted to take a quick moment to say thank you to Crime Stoppers of Halton and CMHA Halton Region branch for collaborating on this. We as the police realize that addictions and opioid use in the community isn't a one-person intervention. It's not the police. It's not all the community partners. It's everybody that takes a role. So again, I just want to really thank you guys for collaborating on this and bringing this together. We realize as the police that enforcement is not the best way to deal with all these different issues. There's a big community part. Harm reduction is huge. So again, thank you guys for collaborating on this. And I want to thank all the people who are tuning into this today as well. Again, the more information you have about things in the community, it's a lot better for you to be able to help people in your own lives or in your professional lives as well. So I hope you guys enjoy the morning. I'm sure you're going to take a lot out of it. And again, thank you all for tuning in today.
Thank you, Rick. Okay, so before we get started, I'd like to go over a few items so you know how to participate in today's event. So we'd like to hear from you during the webinar, but that will be via questions in the chat. We do have a couple co-hosts in the chat from Crime Stoppers of Halton. Their first names are Colin and Pam. You can write to everyone, or you can write directly to them, who will then pass along the questions to the presenters. This webinar will also be recorded and be made available on the Crime Stoppers of Halton's website afterwards. So today we're here to discuss and gain an understanding of addiction and substance use disorder. Halton Regional Police and Crime Stoppers of Halton is partnering with CMHA Halton to provide information on this very important topic. Presenting today will be Danny Sudd, who works for the CMHA Halton, which is the Canadian Mental Health Association. Danny has been a registered nurse specializing in addiction and mental health for the past 14 years. Danny has worked in a variety of settings, including community case management, inpatient psychiatry, and psychiatric emergency services. Sorry, stumbled on my words there. Danny earned his Lean Six Sigma Black Belt certification in 2019 and contributes to quality improvement initiatives that drive successful client outcomes along with critical incident reporting. Danny is also the chair of HOPE, which stands for Halton Overdose Prevention and Education Committee, and is always passionate to share and learn with others while advocating for the most vulnerable and shaking things up whenever he can. Without further ado, I'd like to introduce Danny Sudd, registered nurse with the Canadian Mental Health Association. Danny?
Thank you, Nadine. So can everyone hear me all right? Hopefully we don't have any technical glitches. So thank you guys for joining me this morning and for inviting me to participate in this webinar. Like Nadine mentioned, our topic this morning is In Our Backyard, Opioid Use in Halton Region and How We Can Help. So the objective of this presentation is to gain an understanding of addiction and substance use disorder, specifically as it relates to opioids and its impact here in Halton Region. We're going to be talking about a lot of different topics, and hopefully throughout the course of the presentation, you gain a little bit more of an understanding with respect to what an addiction is. I'm sure we've all heard of the term addiction, we've all used the word addiction, but maybe we're not necessarily aware of what that actually means and how that could be relevant to someone. So hopefully we can answer some of those questions And then we'll talk a little bit more about opioids and what makes opioids so particularly addictive and how they impact us here in Halton Region and what you could do to support individuals that you may know that are struggling with opioid dependency. If you have any questions at any point in time, please do reach out to any of the co-hosts that Nadine had mentioned earlier. So substance use disorder, AKA or otherwise known as an addiction. The Diagnostic and Statistical Manual, which is a medical manual used to categorize different mental health and addiction issues, categorizes specific criteria for somebody with substance use disorder. So just to go over some of those criteria quickly, somebody who's taking a substance, and by substance I'm referring to a drug or alcohol, in larger amounts or for longer than they're meant to. Someone who's wanting to cut down or stop using the substance, but not managing to do so. Spending a lot of time getting, using, or recovering from the use of substances. Cravings and the urges to use substance. That's really big. Not managing to do what you should at work, home, or school because of your substance use. Continuing to use even when it causes problems in your relationships. Giving up important social, occupational, or recreational activities because of your substance use. Using substances again and again, even when it puts you in danger. Continuing to use even when you know you have a physical or psychological problem that could have been caused or made worse by the substance. Needing more of the substance to get the effect that you want, which is defined as tolerance. And the development of withdrawal symptoms, which can be relieved by taking more of the substance. So over the course of the presentation, we'll sort of unpack what some of these mean in a little bit more detail. Furthermore, the DSM categorizes substance use disorder according to severity. And this is something that's relatively new, at least with the latest update of the DSM. The DSM allows clinicians to specify how severe or how much of a problem the substance use disorder is, depending on how many symptoms are identified. 2 or 3 symptoms indicate a mild substance use disorder. 4 or 5 symptoms may indicate a moderate substance use disorder, and 6 or more symptoms indicate a severe substance use disorder. So when we look at somebody with perhaps a mild substance use disorder, maybe that person is a recreational user, right? So maybe they use on a Friday or a Saturday or, on vacation. It's not really impacting their activities of daily living. They're able to remain functional in different capacities of their life. Someone with moderate substance use disorder, perhaps it's beginning to impede their activities of daily living a little bit more, right? So perhaps they're struggling to pay their bills, they might be having some brushes with the criminal justice system or finding themselves in the emergency room, showing up late for work, sort of conflicts in their relationship. So again, they're functional, but it's beginning to sort of show cracks. And somebody with severe substance use disorder is someone who their activities of daily living have been profoundly impacted. So, lots of problems with the criminal justice system, perhaps the dissolution of relationships or termination of employment, they're on a medical leave of absence, any variety of sort of variables that are impacting their ability to function at home, school, or in the community. So with that being said, let's talk specifically about opioids. And I'm sure everyone in this room has heard of opioids or the fact that we're living in the midst of an opioid epidemic. And this is something that's been making headlines for several years now, if not at least maybe a decade, if not longer. Or actually, I want to say it's been making headlines for at least the last 2 decades. Opioids are a broad group of pain-relieving drugs that work by interacting with opioid receptors in the brain. Opioids can be naturally occurring, so anything that's derived from the poppy plant, for example, opium or morphine. They can be semi-synthetic, for example, OxyContin, or they could be fully synthetic, for example, methadone, fentanyl, Suboxone, etc. When somebody uses opioids, there are 4 key systems that are impacted throughout the body. And these four key systems are outlined below. In the brain, opioids bind to receptors to bring about feelings of euphoria. So you have a feeling of elatedness, a feeling of pleasure, happiness. In the intestines, opioids bind to smooth muscle cells that can contribute to constipation because they slow down intestinal motility. And while constipation may not seem like sort of a big deal, it actually can have quite severe implications medically, and in some cases can contribute to death. In the brain stem, opioids bind to receptors that impact your breathing, so how many breaths you take per minute, and your heart rate, so how many times your heart beats per minute. And in the spinal cord, opioids bind to receptors that impact the pain signaling pathways. So in summary, in the brain, opioids bring about feelings of euphoria. In the intestines, they slow down smooth muscle contraction, which can cause constipation. In the spinal cord, they interfere with the pain signaling pathways. And most importantly, in the brain stem, they bind to receptors that slow down your breathing and slow down your heart rate. And this is what makes opioids deadly. The average person takes between, say, 12 to 20 breaths per minute. So if I were to count your respiratory rate, the number of times your chest rises and falls in a minute, it would be somewhere between 12 to 20. So with every breath you take in, you bring in oxygen. With every breath you exhale, you release carbon dioxide, that waste byproduct. So when opioids slow down your breathing, all of a sudden you're in a state where you're bringing in less oxygen. And if you're bringing in less oxygen, you're releasing less carbon dioxide. And in some situations, this can very quickly become fatal because your body's in a state now where it no longer has oxygen to fuel your brain and your vital organs. At the same time, it's accumulating carbon dioxide, that waste byproduct. And in a very short matter of time, this can result in death. And this is why so many people continue to pass away from opioid misuse. It's not necessarily deliberate, it's just that they've used an amount that their body is unable to handle, such that their breathing is slowed down. So when we hear about opiate overdoses, what we're really talking about is somebody whose breathing is impacted, somebody whose respiratory rate is impacted. We often talk about fatal overdoses, right? So the number of individuals that unfortunately lose their lives. In some cases, individuals do survive their overdose. However, because their brain has been without oxygen for a period of time, it could just be a few minutes even, they develop what's known as an acquired brain injury. So I think it's important to sort of recognize, the individuals that survive opiate overdoses and develop acquired brain injuries, as well as those that sadly sort of lose their lives. So opioid withdrawal, right? So what makes opioids so difficult to come off of? When someone uses an opioid, it goes into their body, goes to those receptors in the brain, the pleasure receptors, and it causes them to produce 2 to 10 times the amount of dopamine that would be produced under natural circumstances. So your brain now is awash with dopamine. So you feel great. You feel very euphoric, very elated. Your body, in a very short amount of time, says to itself, hey, why should I bother producing dopamine or investing resources to produce dopamine when this individual is using this external substance that causes it to be produced times 10? So your body, in essence, shuts down its own dopamine factories because it doesn't need to put energy and resources into producing its own dopamine because you're using the opioid that causes it to be produced. So your body shuts down its own dopamine factories, which means you now become pretty much 100% dependent on that opioid to produce dopamine. So your ability to regulate your emotions, your ability to experience pleasure, happiness, manage stress, etc., is now linked to the use of opioids. So while you might be experiencing consequences in your life, problems with the criminal justice system, relationships, workplace, etc., it's difficult for you to stop, because when you do stop that use, your brain doesn't pick up where your body left off, right? So it can take your brain, and this is a scary number, up to 2 full years to get back to a level where it produces its own dopamine sufficiently. So 2 years is a really long time. And that's what makes opioids so difficult to come off of. Because let's say it's Monday morning, you just got discharged from the emergency room, or you just got into an explosive fight with your family or your significant others, and you say to yourself, that's it, I'm not going to use anymore. Well, your brain doesn't pick up where your body left off. So you're going to have a period of time where you feel awful. And that makes relapse all the more common. So what happens, let's say it's Monday morning and you decide, you know what, that's it. My doctor's read me the riot act. I'm about to, get fired. I've been charged. My partner wants to leave me. I'm going to stop using, right? What you can then expect to go through is opioid withdrawal. So withdrawal from opioids is caused by the cessation or reduction of use that has been heavy and prolonged, or by the administration of an opioid antagonist, such as naloxone, after a period of opioid use. So if your body's used to using X amount of opioids per day, and you stop cold turkey, you're going to experience withdrawal. If you decide you're going to taper and cut your opioid use in half, you're still going to experience withdrawal because you're consuming less than your body's used to. Opioid withdrawal is not life-threatening. However, it does pose significant risks for certain population groups. I want to emphasize again, opioid withdrawal is not life-threatening. Withdrawal from some other substances can be life-threatening. For example, alcohol, benzodiazepines, particularly if withdrawal is associated with seizures. But withdrawal from opioids, while it's extraordinarily uncomfortable, it's not life-threatening. The population groups that we need to be very mindful of are women who are pregnant, because women who are pregnant and go through withdrawal face the risk of miscarriage in their first trimester and preterm labor in their third trimester. The gold standard treatment for women that are pregnant at any stage of their pregnancy is opioid substitution therapy, otherwise known as methadone or Suboxone. An individual is also at risk of suicide during withdrawal, particularly if it's sudden, untreated, or forced. And that's because the withdrawal is so uncomfortable that an individual may decide to die by suicide than to go through that process. So it's so important that individuals that are in the early stages of withdrawal really have the right supports around them so they don't die by suicide or experience a relapse. Due to a loss of tolerance, people who go through withdrawal are at high risk of overdose if they use again. So your body develops a tolerance to opioids very, very quickly. And by the same token, your body loses that tolerance very quickly. So if you're someone who is accustomed to using X amount of opioids per day consistently, and you end up in a situation where you no longer have access to that quantity of opioids, your tolerance is going to drop in as little as a few hours. So for example, if you use X amount of opioids per day and you end up in the emergency room and you're in the emergency room for say 6 hours, 12 hours, 24 hours, or you go into a residential treatment program, or perhaps you're incarcerated for a period of time, your tolerance is going to drop such that when you go back to the community, if you resume using the dose that your body was previously able to handle, You'll overwhelm your brainstem, right? And remember, breathing gets impacted, so you can cause an accidental overdose. So it's so important when we're supporting individuals, if that individual has abstained from opioids for a period of time, again, by way of hospitalization, incarceration, residential treatment, or even if people have managed to do quite well with their community-based plans, we really support them and let them know that if they're going to have a slip or a relapse, to put some measures in place to keep themselves safe. And by keeping themselves safe, we're really talking about keeping themselves alive. And we're going to talk more about that. So opioid withdrawal. Again, so let's say I decide that it's Monday morning, it's 6 a.m. The opioids have caused enough problems in my life, I need to stop using. All right. So I take my last use at say 6 a.m. Well, withdrawal will kick in between say 6 to 24 hours after last use. So sometime between Monday noon and Tuesday morning at 6 a.m., those withdrawal symptoms are going to begin to kick in. Those symptoms include nausea, vomiting, diarrhea, pins and needles sensation, which is the activation of your sympathetic nervous system, really bad sort of restless legs, insomnia, agitation, restlessness, runny nose, abdominal cramps, muscle aches and pains. The list goes on. It's extraordinarily uncomfortable. So those symptoms will kick in 6 to 24 hours after last use. They continue to get progressively worse and peak on day 3. So if you thought day 1 was bad, day 2 is worse, and day 3 is even that much more uncomfortable. So again, really support your family, your friends, your significant others to recognize, you know what, this is going to get a lot worse before it gets better. And years ago, when I started my nursing career back in 2007, I worked at CAMH in Toronto at their medical detox facility. And at the time, I was a brand new nurse, and my understanding of opioids was quite different. But I noticed a lot of the individuals that we would admit to medical detox would check themselves out against medical advice, otherwise known as AMA, before that 3rd day, because the symptoms were just so uncomfortable. They decided, you know what, now's not the time, right? I can't do this today. Maybe I'll try again next month or next year or whatnot, right? So supporting individuals during those first 3 days is critical. Now, medicine can buffer some of these symptoms, but we can't eliminate them, right? So with the use of appropriate medications, we can bring some of these symptoms down from say maybe a 6 or an 8 out of 10 to maybe, a 2, 3, or 4 out of 10. So it's going to be uncomfortable. No one wants to feel this way, which is why a lot of people, unfortunately, have slips and relapses. And again, keep in mind, while they're going through this, their brain has very little dopamine. So in addition to all these horrible physical symptoms, they're just going to feel so low. And in some cases, they may feel suicidal, right? So really recognizing that this person is in need of medical and psychosocial supports is so key. And again, the risk of relapse is so high. And again, their tolerance drops super quickly, right? So if you manage to go and get through day 1 and day 2, and finally, before day 3, you decide, I can't do this, and you go back and use, you really need to start slow because your tolerance has dropped. If you go back to using an amount your body was able to handle, you might cause an accidental overdose, which would result in death in some cases. So how do you manage opioid withdrawal? So there's a few different options. The first is abrupt cessation or cold turkey. So that's where somebody abruptly stops using opioids. I have very seldomly seen this be successful. Why? Because the withdrawal symptoms are so uncomfortable individuals struggle with such low mood that stopping cold turkey seldomly works based on my experiences. Another option is tapering protocols. So a decrease of 10% of the original dose every 1 to 2 weeks. Now, this is what I read in a lot of sort of best practice guidelines, right? And a lot of sort of peer-reviewed publications. What I've experienced is somebody that's struggling with opioid dependency that goes to their family doctor and says, "Doc, I'm using 100 milligrams of OxyContin every single day, right? Or 20 Percocets a day, right? Or X amount of fentanyl. I need you to reduce that 10% of the original dose every 1 to 2 weeks." The doctor's going to tell you to get lost, right? I've not yet met a doctor who's going to follow, this tapering recommendation. What some doctors will do, based on my experience, is perhaps a really rapid taper, right? Which again is going to be very uncomfortable. So while I see that recommended in sort of best practice guidelines, I've never seen it done. Usually individuals that struggle with addictions have a very sort of hot and cold relationship with the medical community. If they go to the emergency room, they're not getting a prescription for 10% of their original dose every 1 to 2 weeks. I guarantee you they're not getting that, right? If they go to their family doctor and they disclose that they have an addiction, their family doctor might tell them, "You're fired from my practice. I don't want to see you come around here anymore." If you go to a walk-in clinic, how many times have we been to a walk-in clinic and we see those signs up saying this clinic does not prescribe opioids, right? So really, tapering protocols are really tough. How do you manage it with medications? This is successful. So using a combination of over-the-counter and prescription medications to, again, manage, not eliminate symptoms. And the gold standard treatment for opioid dependency is opioid agonist therapy, which again is a fancy word for substitution therapy, also known as methadone or Suboxone. So both methadone and Suboxone are ultra-long-acting opioids. So we treat opioid dependency with opioids, but this is what makes methadone and Suboxone different. At their therapeutic dose, methadone and Suboxone goes into your body, it binds to those receptors in the brain, and at the therapeutic dose, it prevents you from going into withdrawal, and it prevents you from craving for a full 24 hours. All right? So by preventing you from going into withdrawal and preventing you from experiencing cravings for a full 24 hours until your next dose, you're sort of physiologically or medically stable, right? Because you're not going into withdrawal and you're not having cravings. People that struggle with opioid dependency, they need to use, every few hours, right? Because they need to sort of avoid going into withdrawal. So again, at the therapeutic dose, methadone and Suboxone last for a full 24 hours. So the folks that I support that are on methadone or Suboxone, I always encourage them, take your dose at the same time every single day. So if you're used to taking your methadone or Suboxone at 9 a.m., please take it at 9 a.m. every single day, give or take maybe an hour or so. What really worries me is the individuals that take it 9 a.m. one day, 2 o'clock the next day, they miss the third day, and they're just sort of all over the place. Because in those cases, they don't have that steady supply of opioids in their, they don't have that steady supply of methadone or Suboxone in their system. So they're at risk of going into withdrawal and going to experience cravings. So recommendations, again, suggest you stay on it for a minimum of 2 years. Why 2 years? Because this is where the hard work begins. You have to begin sort of fixing or repairing all those different components in your life, right? So, your relationships, your employment, any legal matters that you might have, how to take care of yourself, how to cope with stress, how to regulate your emotions. And honestly, that's the hard part, right? Sort of the medical stuff is easy, right? But the hard work is, learning how to regulate your emotions, right? So that's where, our community partners are so critical because, we can support individuals for longer terms, right? So this way we help them get as stable as possible in their lives. Again, what worries me is when I'm working with somebody who just as quickly as they got started on methadone or Suboxone wants to get off, right? And so many people, they tell me they want to get off it because it rots their teeth, it's a form of substitution. So in those cases, I really encourage individuals to consider, how their lives can change if they have skills and tools under their belt. Furthermore, I provide those individuals with a lot of education on how methadone and Suboxone are medications that can allow them to function and feel normal. There is another medication as well that's used to treat opioid dependency, and that's naltrexone, and it's an opioid blocker. All right, so that just blocks all the opioid receptors. So this way, if somebody uses, it prevents them from experiencing the effects of the opioids. Naltrexone is not covered by the Ontario Drug Benefit. However, you can get coverage for it if your doctor completes a few extra forms to request it. So, reduced tolerance, and we talked about this sort of earlier on. Tolerance is your body's ability to process a certain amount of a drug. Low tolerance means that your body can only process a small amount of the drug. And tolerance to opioids drops very, very quickly, which increases the chances of an accidental overdose. So again, sort of the take-home message from this slide is, if you know somebody struggling with opioid dependency, if they've had a period of time where they haven't used, their tolerance has dropped, right? Guaranteed. So ensure that you support that person such that if they do use, they keep themselves safe. And I've been in this field for many years, and what I find most disheartening is when I get a text message or a phone call, or I find out from colleagues that somebody that I know, a patient, a client, has passed away, sort of suddenly, right? And sort of 9 times out of 10, it's because that person had reduced tolerance, then decided that they were going to perhaps use or test themselves, or they sort of convinced themselves that I can handle it, I've got it under control, and they accidentally lose their lives, right? So it's an accidental overdose. So tolerance, let's talk about tolerance as much as possible. So some numbers nationally. Between January 2016 and September 2018, there were 10,300 opioid-related deaths in Canada. This is, without a doubt, a public health emergency. And again, we're talking about sort of a pre-COVID era, right? However, the data that's coming out still supports the fact that individuals are passing away at alarming numbers because of opiate overdoses. Interestingly enough, in the summer of 2019, Statistics Canada put out a report. And I remember, because I was flabbergasted when I read this. Statistics Canada, which they monitor the vitality of the country, right, and how we're doing as a developed nation. They had said in the summer of 2019 that for the first time in decades, our life expectancy as a nation had dropped, right? And they attributed that drop to the opioid epidemic from coast to coast. And that blew me away. And I have been in this field for a while, but for me to read a report from Statistics Canada saying that the life expectancy of the country has dipped because of the opioid epidemic blew me away. And even repeating that to you guys today still sort of gives me chills. So no doubt, public health emergency. Again, for opioid monitoring, some local statistics. Between January 1st, 2020 and December 31st, 2020, in Halton Region, there were 241 suspected overdoses, and 38 of those overdoses were fatal. Now, I suspect these numbers are actually quite higher, right? Much higher than we see here. The problem is, collecting data can be a bit of a challenge. So this is the best that we have available. But in reality, I think these numbers are much, much higher. The majority of individuals who died as a result of a suspected overdose last year died alone. Pretty scary, right? So again, when we talk about how to keep yourself safe, if you have a reduced tolerance or you're in recovery, go slow, right? So use a test dose, use a small amount, right? Don't use alone. Let someone know. Have a naloxone kit, and we'll talk a little bit more about what naloxone is. Know your source, right? So know who you're getting it from. While you can never be 100%, these strategies at least help in some capacity. Emergency room visits. So the number of emergency department visits for confirmed opiate overdose by hospital aged 10 and up in Halton Region from July 2019 to June 2020 are below in this graph. So you can see Halton South, OTMH, and Joseph Brand have seen a lot more. And again, I think these numbers, which were compiled by Halton Region, I think these numbers are really low because when some individuals present to the emergency room because of an opiate overdose, that visit might be categorized as something else. So for example, it may be categorized as a suicide attempt. It could be categorized as a psychosis, as a major depressive disorder. So, a lot of times opiate overdoses perhaps sort of get hidden under other sort of medical or psychiatric diagnoses. So again, these numbers probably really, really low. Opioid-related deaths. Again, these are some numbers from Halton Region. But again, I think these numbers are significantly lower than what we see in reality. Because again, a lot of the deaths may be categorized under other sort of topics, right? So, suicide being sort of the primary one. So what's an overdose? We spoke about this again at the beginning of the presentation. An overdose happens when a person takes an amount of a drug or a combination of drug that is more than their body can handle. As a result, their central nervous system is not able to control basic life functions, such as breathing, temperature regulation, heart rate, and your respirations drop. So an opiate overdose is a medical emergency. It's also important to note that while opioids slow down breathing and heart rate, benzodiazepines also do the same thing. So by benzos, I'm referring to, clonazepam, diazepam, lorazepam, alprazolam, also known as Xanax. So any of the benzos do the same thing. They slow down breathing, slow down heart rate. Alcohol does the same thing, slows down breathing and slows down heart rate. So if someone is misusing opioids plus benzos plus alcohol, or all three of them, or any combination, the effects are compounded, right? So we really have to screen for those individuals that might be polysubstance users. Now, it's also important to recognize that some individuals, they actually have legitimate prescriptions, right? They might have a prescription for their knee pain. They may also have a prescription, for their anxiety. So in some cases, an individual is not a recreational user, but they simply have prescriptions for these medications kicking around at home. So letting folks know how to use these medications safely is also key. When I talk about this, I sort of think of my grandmother, right? She's in her 80s. She's got, lots of chronic pain in her knees. When I go over to my grandmother's house and I look at, the kitchen table, I see prescriptions for opioids. I also see prescription for benzos. So it's important that we have those conversations with our loved ones and we let them know, hey, if you're going to use this combination of medications, space them out, right? Know the risks. So I think that's important to sort of recognize. And again, minimize your use of alcohol if you're on opioids or you're on benzodiazepines. So how do you recognize an opiate overdose? So we all, by this point, know it's a medical emergency. What are the signs? So what should you look for? And this slide summarizes that. So the person is not responding. They can't move or they are unable to be woken up easily, right? So, you're rousing the person, you're shaking the person, you might be doing a sternal rub. The person can't seem to wake up. Slow breathing or not breathing at all, right? And this ties in with the decreased respiratory rate that we talked about. They're making gurgling sounds, right? So, it sounds like they're choking or gargling or snoring. Their lips and nails are slightly blue or cyanotic, cold and clammy skin, and tiny pupils. So if somebody has any combination of these symptoms, they may be experiencing an accidental overdose. Someone doesn't need to be experiencing all, they could just have one, right? But when you begin to see these symptoms, think to yourself, could this be an opiate overdose? So in the event of an opiate overdose, what can be done that is life-saving? And that ties together, or that sort of leads to our discussion on naloxone. Naloxone has been declared an essential medication by the World Health Organization. It is an opioid antagonist, meaning that it has a higher affinity for the opioid receptors and can reverse the effects of an opiate overdose, temporarily restoring respirations. So in a nutshell, if somebody is under the use of opioids and you introduce naloxone into that person's system, the naloxone will go into their body, it will go to the opioid receptors in the brain, and because it has a higher affinity for those receptors, it'll kick all the opioids off the receptors. And it will bind to those receptors. So it will very instantly put that person into withdrawal and temporarily restore breathing. And the best analogy I can use for somebody who has received naloxone, it's almost like they're coming up from, being underwater and taking a gasp of air, right? So it's like right? All of a sudden they're bringing in oxygen into their body, right? So that's what naloxone does. If you suspect an opiate overdose, what to do? So first and foremost, remain calm. Look for the signs and symptoms that we discussed. Call 911 and tell them the person is not breathing, all right? And I know there's like police on this call, right? But I've been in situations where I have been with somebody that's overdosed. They're breathing, but I still tell 911 they're not breathing, right? Why? Because I want 911 there as fast as possible. Because again, remember, every minute that goes by where that person's not getting oxygen in their brain can either contribute to death or an acquired brain injury. So I just tell 911 they're not breathing, right? Because I want to get paramedics there as quickly as possible. If you have access to naloxone after you've called 911, you're going to want to administer it. If you've got the injectable naloxone, break the ampule, pull it into the needle slowly, and inject it into a large muscle. I don't like the injectable naloxone. It's too many steps, right? And if I'm not a medical professional, you're asking me to break an ampule, then pull it into a needle, find a large muscle. I don't know what I'm doing. I'm nervous. My hands are shaking. I hate the injectable naloxone. What I do like is the nasal spray naloxone because that is easy. All right, and we'll go over what the nasal spray naloxone is shortly. With the nasal spray naloxone, all you have to do is open the package, put it into a nostril, and depress the plunger. I can manage that when my hands are shaking and when I'm nervous, right? After you've administered naloxone, you're going to want to check if the person's breathing. If they're not breathing, you're going to want to give chest compressions until help arrives if you're trained in CPR. That's if the person is not breathing. If the person is breathing, please put them in the recovery position, all right? And we have a bit of a diagram of what the recovery position looks like. And the reason you're going to want to put the person in the recovery position is so that if they vomit, the vomit flows out of their mouth. So this way they don't choke on their vomit because, they could die by choking. So how do you administer the nasal spray naloxone? Super easy, all right? Each naloxone kit comes with 2 cartridges. All you have to do is peel open the wrapper, put it up someone's nostril, and depress the plunger. That will deliver 1 4-milligram dose of naloxone. Each cartridge is single use only. So please don't test it, don't prime it, just shove it up their nostril and depress the plunger. How can you tell if it's working? So naloxone usually starts working in 2 to 3 minutes. So if you've administered the first one, you should notice within 2 to 3 minutes if it's made a difference. If the person is not responding or still not responding, you're going to want to administer the second dose using the other nostril and use repeat doses if available. There are some cases that I've learned about from Halton Region, specifically the needle exchange program, where some individuals require multiple doses, right? So they've taken, between 4 to 6 hits of naloxone before they were able to be revived. So that could be a reflection of the fact that they were under really strong opioids, or, the people that were using the naloxone simply weren't waiting 2 to 3 minutes. And I mean, I get it, right? If I've got somebody that's overdosed in front of me, 2 to 3 minutes is going to seem like 2 to 3 hours, right? So, I'd be shoving as many naloxone kits as I can up their nostril. So again, if you have a watch or your phone, give it that 2 to 3 minutes before administering the second one. Again, continue chest compressions and or rescue breathing until help arrives. In the age of COVID, rescue breathing, it's up to you, right? Chest compressions is probably the single best thing you could do to keep the heart pumping. If you've administered naloxone, 2 doses, you've done the 2 to 3 minutes, and it's still not working, that can mean one of a few things. Either the person is not under the influence of opioids, or a higher dose of naloxone is needed, or there could be something else going on, medically. If in some cases the person's under a high dose of opioids or strong opioids, in some of those cases, when the person gets to the emergency room, naloxone is administered intravenously. So, it's hard to tell based on what your observations are until the person gets to a hospital. So naloxone, you have the power to save a life. For anybody that might have a smartphone, feel free to scan those codes below to learn more about opioids and how to use naloxone appropriately and how to administer it. How do you get a naloxone kit? So hopefully in Ontario, any person can walk into a pharmacy and request a naloxone kit. It was deregulated many, many years ago. And part of the reason why it was deregulated was so that it could get into the hands of community members as easily as possible and without barriers. So walk into a pharmacy, ask for an naloxone kit. You may be asked for your health card. You may get an injectable naloxone. You may get nasal spray naloxone. I'm not sure. It depends on the pharmacy. Hopefully you get the nasal spray naloxone kit. If you go into a pharmacy, they will ask you for your health card. All right. Some people don't really want to provide their health card. They don't want this documented somewhere. Some people, a lot of people don't even have a health card. So if you would like a naloxone kit, but going into a pharmacy and getting a naloxone kit is something that you're uncomfortable with or unable to do for any reason, not to worry, because naloxone kits are also available through Halton Region, the Needle Exchange Program. Any of the public health and sexual health clinics, they're available through community-based organizations, including the Canadian Mental Health Association, Halton Region branch. So there are many ways we can get you a naloxone kit confidentially without taking your identification, right? So, reach out to us, reach out to public health, ask the police, right? The police will also be able to help point you in the right direction. So I want to talk briefly about the Good Samaritan Drug Overdose Act, which was passed on May the 4th, 2017, also known as Bill C-224. And I'll read a quote from the then Honorable Jane Philpott, who is the Minister of Health. During an overdose, a call to 911 can often be the difference between life and death. We hope that this new law and the legal protection it offers will help encourage those who experience or witness an overdose to make that important call and save a life. And I really think this is such a key piece of legislation that was passed, because prior to this, if somebody was experiencing an overdose, and they were with friends or significant others, and perhaps there was legal involvement, they were worried about, whether if I was in breach of like my probation conditions or my legal imposed conditions, what if I get charged with possession? So what this law does is it offers some protection if an individual is in breach of the following conditions under Section 4.1 of the Controlled Drugs and Substances Act. So, for example, if they're in breach of parole, pretrial release conditions, probation orders, simple possession, conditional sentences, etc. It does not protect against outstanding warrants or the production and trafficking of controlled substances. So hopefully through this, people or individuals are more inclined to call 911 and get help rather than just sort of disappearing, right? And leaving that person to suffer and possibly pass away. The police are very familiar with the Good Samaritan Overdose Act. There's a lot of knowledge out there. And like the officer was speaking about at the start of this presentation, they're really looking at ways to support individuals struggling with addictions, because the community recognizes that it's a really complex biopsychosocial issue, right? And not necessarily an issue that could just be resolved through the justice system. So some harm reduction strategies, all right? So when I talk about harm reduction, and I'm a big believer of harm reduction, and the research supports harm reduction, all right? Harm reduction is about minimizing or mitigating the consequences associated with drug use, all right? Expecting someone to be fully abstinent may not necessarily be possible, right? So how can we support someone to use safely so the harms associated with their drug use can be minimized? So for example, never use alone. Have another person nearby that could potentially save your life by calling for help. Be mindful of tolerance, so use a small amount of a drug first to check the strength, but remember that any drug can be cut with or contaminated by other drugs, which can be harmful or fatal. Carry a naloxone kit. call 911. Again, under the Good Samaritan Drug Overdose Act, you have certain protections. Offer clients that you know that might be using intravenously, clean, sterile needles. All right. Halton Region operates the needle exchange program. One of the more common things that I see with intravenous users that reuse needles is endocarditis, right? So an individual that might be reusing certain needles, even if it's just on themselves, introduces bacteria into their body. And by using the same needle over and over again, that bacteria continuously gets introduced into their body, travels around their blood vessels, and for whatever reason, it always latches on to valves in the heart, right? And it begins to grow, right? And now you've got vegetative growth on your heart valves. I know someone who is in their 20s that had to have, because of their intravenous drug use, they had to have artificial valves put in because there was just so much bacterial growth on the valves of their heart. And they also had endocarditis, an infection of the heart. So always offer clean, sterile needles. Let people know they can get clean, sterile needles from the needle exchange program. By minimizing individuals sharing needles as well, you'll minimize, HIV, hepatitis, or any other sort of communicable illness. Also, encourage people to dispose of their needles safely. All right, so you can go into any pharmacy and get a sharps disposal kit at no cost. All right, so looking at ways you can equip people with sharps disposal kits. If you're part of an organization, perhaps looking at your organization and perhaps looking at those bathrooms that you might have and seeing, are there sharp disposal kits in those bathrooms? And if not, maybe approaching your team and saying, hey, you know what, is this something that we can look at? A lot of drug use happens in bathrooms, right, or bathroom stalls. So rather than just having individuals throw them out or leave them on the ground, give people the tools to dispose of them safely. So some community resources. We've talked about an awful lot this morning, right? So please forgive me if we went through the content at an extraordinary pace, but if you would like more information, or if you would like to support someone in your life, we have the good fortune of having a lot of community resources in Halton Region. Some of them I'll outline on this slide. First and foremost, the Canadian Mental Health Association Halton Region branch. So we offer a variety of services, including crisis support, case management support. We have a designated opiate nurse. If you need any type of support, CMHA is a good place to start. Check out our website to learn more about some of the programs available. We also work in partnership with a number of other organizations, Joseph Brant Hospital being one of them. We have a partnership with Joseph Brant Hospital to support individuals with individuals that are requiring crisis stabilization and support. That's the FAST partnership. So Joseph Brant Hospital is a great resource. Halton Healthcare is a great resource. The Needle Exchange Program through Halton Region, Halton Adapt. So these are all organizations that we work closely with, but also organizations that have their own robust supports as well. So feel free to take down any of those numbers or just look up their websites to learn a little bit more. We also have a lot of RAM clinics sort of within Halton Region. A RAM clinic stands for Rapid Access to Addiction Medicine. So this is where you'll have a doctor, a medical doctor, prescribing medications to help with substance dependency. So locally in Halton Region, we have Dr. Holub, who has clinics in most parts of Halton. He will help do an assessment and support individuals that are struggling with substance dependency by prescribing them medications to minimize cravings, minimize withdrawal symptoms. So his contact information is there. If you're working with individuals in sort of the Hamilton region, Dr. Anjalil Gupta, who has the SUDS clinic, Substance Use Disorder Service, she's a great resource as well, and she's also one of the emergency room physicians at Joseph Brant Hospital. Opioid specific clinics, so clinics that just deal exclusively with opioid dependency. We've got Dr. Bawa, who has clinics throughout Halton as well as Peel. His contact information is there. And we've got Dr. Sheldon Hirschkopf on Spears Road. And if you're outside of Halton or you're outside of any of these sort of catchment areas, just call Connex Ontario. Connex is the provincial organization that sort of manages all the addiction and mental health resources. So just give Connex a call, let them know your information, and they'll do a screener with you and point you in the right direction wherever you are in Halton Region or in Ontario. So here's just some references for the presentation. So we'll see if we have a bit of time for any questions that might come up.
Thank you, Danny. That was great.
Thank you.
So yeah, we did get some questions that have come through on the chat. So one question is, if you think someone is experiencing an opioid overdose and naloxone is administered, but it turns out the person was not under the influence of opioids, will there be a negative consequence for that person now that they have been given naloxone?
So thank you. This is such a great question. No. If you've administered naloxone and it is unrelated and it turns out the person is not experiencing an opiate overdose or there's something else going on, nothing will happen, right? You will not cause that person to experience any further decline in their health. You will not be introducing anything negative into their system. It simply will be benign, right? So if in doubt, administer naloxone. And again, if the person's not under the influence of opioids, nothing will happen, right? So it's an extremely safe medication. And Ontario and sort of the government would not have deregulated it and made it available en masse if there was the slightest type of risk or liability, right? The province is very sort of risk averse. So, there's no risk with it.
Perfect, thank you. Another question, is it possible to ask for the nasal spray variant of naloxone specifically?
So you can, right? And I think I would encourage everyone to ask for the nasal spray naloxone because it is so much easier to use. The only sort of challenge might be, does the pharmacy or the location that you go to have it in stock? The nasal spray naloxone is a little bit more expensive, so some locations may not have it. All right. If you would like a nasal spray naloxone kit, go to the province's website, ontario.ca, and look for specific locations that you can get a nasal spray kit. All right. So yeah, I would encourage you to call ahead. We're trying to ensure many distributors have the nasal spray, but some places all they can get is the needle, the injectable.
Okay, thanks for that. One other participant wanted to know, does opioids affect your food intake?
Yes, right? Individuals, so how it affects your food intake and how it affects your appetite, I'm not quite sure, but I do know that individuals that are struggling with opioid dependency, based on my experience a decrease in their appetite, lots of weight loss, lots of dental health issues. So there are significant impacts on their appetite based on my experience. How that works, I'm not entirely sure.
Okay, a couple more questions. Can you talk about how long, how much use of opioids is needed to develop an addiction?
So great question. This is really unique and specific to each individual. So someone may develop an addiction in a matter of a few days, depending on how they used, what they used, what's going on in their life at the time, right? The feelings that it brings about in that person, what their support networks are like, right? What their living situations are like. So it's so variable. Individuals that use intravenously are at greater risk of developing a dependency much faster versus somebody who might be swallowing a tablet. Individuals that snort are at greater risk. Individuals that are under a significant amount of stress, right, that might be looking for relief might be at greater risk. Somebody who has underlying mental health issues, such as depression or anxiety, might find that, hey, you know what? When I use this opioid, my mood is better, right? I'm less depressed. I'm less anxious. I can actually go up and introduce myself to individuals without feeling overwhelmed. Individuals with a past history of trauma. So it really depends on that person and what's going on in their life at the moment. So yeah.
So specific to each individual.
Yeah.
No set amount.
Yeah.
If you know someone who has a substance abuse disorder, what is the best way to address it with them? And is there any support for somebody who is the support system for somebody who's using?
Absolutely. So great. So some really good questions, right? If you know somebody that's struggling with substance use disorder, regardless of what substance it might be, it could be recreational, prescription, or otherwise, letting them know that they're not alone, right? And supporting them as best as you can without judgment. Individuals that are struggling with addictions carry a lot of guilt. They carry a lot of shame. There could be intergenerational trauma. There could be any number of variables going on in their lives. So letting them know that they're not alone and perhaps asking them, what can I do to support you? It's very common for all of us to go into sort of problem solving mode, myself included, right? But really encouraging the person to let you know what it is that they need, right? So, just supporting them, asking them what you could do to support them. Now, this can be extremely overwhelming for the significant other, the family member, the friend, all right? We don't know how to cope with our own feelings, let alone, how to support somebody that's in active addiction. In those cases, I would encourage you to really focus on your self-care, right? So, don't lose sight of the things that you enjoy. Don't lose sight of your identity, right? Um, uh, don't neglect yourself in that process. And again, we're here to support you at CMHA. ADAPT has a family support group as well. Just reach out, right, and start those conversations as gently as possible.
And Danny, just to follow up, during COVID, is there still in-person support, or is it mostly Zoom and virtual?
So this will depend on the organization. It's my understanding right now that a lot of organizations have successfully pivoted to providing support digitally. So using Zoom, Ontario Telemedicine Network, phone, text, and in some cases, those face-to-face appointments can occur with the right screening and precautions in place. So again, it depends on the organization. And what's going on by way of the individual's needs. But speak to your case manager, speak to the organization that you might be working with to really explore how your needs can best be met. And I'm confident that we'll all work with you closely to figure that out.
Okay. Another participant wants to know, are there any dangers or possible harm associated with misunderstanding symptoms and administering naloxone to a person who is not experiencing an overdose?
I would personally much rather you administer it and be wrong, right? Than you sit there and sort of, be unsure and then really have the person be struggling with an opiate overdose. So, if you just see one symptom, administer it, right? Particularly if that one symptom occurs against the backdrop of perhaps somebody that's struggling with substance use dependency, or someone that might have access to opioids, someone who has past chronic pain issues. I would always err on the side of caution. And, I think of an example in November of 2018 where I arrived at a client's home and his landlady let me in, right? And she was very sort of frantic. And, she pointed me in the direction of his room, and he was lying in an unresponsive state. I didn't know what was going on, right? But I knew this person was at risk. I administered naloxone, right? So, he had a couple of the symptoms that we highlighted. I administered it, and I would do it again, right? Because I'd much rather administer it than not, only to sort of, second guess myself.
Great, thank you.
Thank you.
Another question, how can you handle someone, or how could you handle someone with addiction issues being prescribed opioids as painkillers by a doctor? Can you ask to be given something else, or are there safeguards you can put in place for them?
So this is really tough, right? Because I don't know what it's like to live with chronic pain, but everybody that I know that struggles with chronic pain is looking for relief. The challenge with opioids is that long term, they do more harm than good, even with individuals that struggle with chronic pain. Because systemically, opioids wreak havoc on your body. So there are other options that an individual can speak to their doctor about. So, for example, somebody with fibromyalgia or nerve pain can speak to their doctor about neuroleptics. You could speak to your doctor about sort of a more holistic approach. So, massage and other modalities of treatment, including physiotherapy. If you're concerned about somebody misusing their prescribed opioids, you can also speak to the doctor about daily dispensing or weekly dispensing. So instead of a doctor giving a 3-month supply, perhaps saying, hey, doc, you know what? I'm at risk, so can you just dispense a week at a time? Right? So this way, I just have 7 days worth of Percocets instead of, 3 months worth of Percocets. So again, this is a conversation best had with doctors. And, doctors struggle with treating chronic pain. Doctors struggle with treating addiction, right? This is not something that, is really openly talked about. So just have conversations with your doctor. And if your doctor's not sure, just keep asking, right? Reach out to your community organizations, reach out to the RAM clinic, just keep talking to people, right? Yeah.
Okay, so are there any specific things to know about working with teens who may be using opioids when providing community counseling support?
So I think, any young person that's using opioids or any other substances, clumping them in with the adult population may not necessarily be the most appropriate solution, because, the pressures and the needs on youth that misuse substances are very different than adults. So I would encourage you to reach out to youth-specific organizations. In Halton Region, ADAPT has a great youth program. ROC, the Reach Out Center for Kids, has a great youth program. So I would really try to ensure that the supports put in place are specific to youth. And again, encouraging safe conversation, ensuring that you as a significant other, parent, family member, friend, you have naloxone kits around. You let your young people know where to use that, where to get that naloxone kit, have many of them around, just to create a safer space, because young individuals are at risk. A lot of young people pass away. So at least if you can let them know where the naloxone kit is and have open conversations about that, you're a step ahead.
For sure. That looks like all the questions. There was just one more kind of statement about naloxone being available for family support. So again, it's not just people with substance abuse disorder that need to carry it. Anybody could carry it, correct?
Yes, correct. Right. And again, interestingly enough, there's a nurse that I work with who told me there's this restaurant on the Burlington waterfront called Spencer's. And many years ago, she was dining at Spencer's for dinner. And next thing you know, one of the wait staff is asking, is there a doctor or a healthcare professional around? And there was somebody that was unconscious. And to make a long story short, this person was struggling with an opiate overdose, right? So, I mean, you could be in a restaurant and just have your naloxone kit in your purse and potentially make a difference, right? So, naloxone kits are better out in the community, right? The more kits we get in the community, the better. I should let you know that naloxone kits are most effective when maintained at a certain temperature. So if you're like myself and you're always on the go and perhaps you've left your naloxone kit in your car on a hot day or a cold day, just replace it. All right, get a new kit. If all you have in an emergency is your naloxone kit that's been sitting in your hot trunk or your cold car, still use it. It's perhaps a little bit less effective, but it's better than nothing. And again, you'll do no harm. Naloxone kits also carry an expiration date. So if you have a naloxone kit and it's expired, get a new one. But again, if you're in an emergency and all you have is your naloxone kit that expired like whenever, use it, right? Because it's going to be a little bit less effective, but just use it, right? It's better than not using it. These are such awesome questions, guys.
So I think I was just corrected. I think I thought it was a typo. Lori typed in that there's a support group for family members, and it's Naranon.
Naranon. Yeah,
Okay.
thank you.
Okay.
Thank you,
Yeah.
Lori, for mentioning that.
Yeah, sorry, Lori. I thought you had typoed naloxone wrong. So thank you for correcting me on that.
Oh, Nard. Yeah. So there's
Okay.
Naranon, there's Al-Anon. So Al-Anon's for families that are supporting individuals with alcohol dependency.
Okay, perfect. Well, there's no other questions, and we are 10 to 12. So thank you so much, Danny. You are a
Thank
great
you, guys.
presenter and a wealth of knowledge.
Thank you.
I definitely learned some stuff. I think we all think that we know a lot, but obviously you know a lot. So thank you for sharing that with us.
Thank you, everyone. It was a pleasure chatting with you again today. And the conversation's just getting started, right? The more we can start talking about addiction and mental health, the more we're going to be shattering those barriers, right? This is not an easy topic. So keep talking about it, keep asking questions, keep challenging individuals when perhaps you might hear things that might be incorrect or judgmental. I think we're all in this together, and let's just keep doing what we're doing.
I agree. It's not, like you said at the beginning, it's not just one person's problem. The police aren't going to fix it. One agency's not going to fix it. The medical system's not going to fix it. It has to be a collaborative intervention and support for people who are, unfortunately suffering from substance abuse. All right. Thank you, everybody. Enjoy the rest of your day. Thank you again, Danny. Thank you, CMHA Halton.
Thank you, everyone.
Thank you. Have a good day.
You too, everyone. Bye-bye.
Bye.